Good morning, everyone. So we'd like to get started. Good morning, everyone. We'd like to get started. My name is Naz Qureshi. I work here in Nottingham. On behalf of the organising committee, Centre for Spinal Studies and Surgery, we are delighted to welcome you to Britspine 2016 in Nottingham. We are truly honoured to be hosting this event for the second time. I'd especially like to extend a very warm welcome to all our delegates and presenters, especially those attending a Britspine event for the first time. We've worked pretty hard over the last 2 years together with the spinal societies to bring together what we think is quite a balanced academic programme. It is somewhat ambitious, but our goal is that you feel inspired, excited and challenged over the next 3 days. Challenges are, after all, what makes life a little bit interesting, and overcoming them makes it that little bit more meaningful. We work and live in a healthcare environment of change. You may not like this. Changes may be are predictable. There may be positives and negatives. But in my opinion, the best way to manage change is to prepare for it, to anticipate it. And it's with this in mind that we've organised some really key sessions for you this year. So you will see in your programme, there's a consent session today at 11 o'clock. There's the UK SSB Spine Care Strategy session at 2020, which is at 2 o'clock this afternoon, including the GIRF project. There'll be some really important talks on the national low back pain pathways, the radicular pain pathways, part of the spinal transformation project. And I understand that there is also an exhibition on this outside. There's a talk tomorrow afternoon at 2 o'clock on perspectives in current healthcare developments. You would have been given some pre-reading material. Please do try and have a glance at this before the individual sessions. I'd like to express my sincere thanks to the programme committee, to all the spinal societies and the executive team, to the industry and sponsors without whom this meeting would not be possible. Please do spend a little bit of time visiting them. You couldn't have missed the exhibition, so it's on level 0 and also on level 1. The industry workshops are on level 2. I'd like to thank our national and international faculty, the SRS faculty who I've had the pleasure of working with very closely in the past. And I think that we must study the past in order to define our future. And it's with this in mind that I'd like to welcome the Grandmasters this afternoon at 4:30. So they're going to be sharing the wealth of their experiences later on. I'm grateful to you all. I'd like to remind that all speakers to upload their talks. This will be in the green room, so that's the glass-fronted room. As soon as you come in through reception, it's on the right. For the first time, all sessions will be recorded and filmed. So if any of the speakers have any objections to this, please do let myself know or one of the programme committee. I'd like to highlight the app, the event app. In this little booklet, it tells you how to download this. This is really important because you'll be able to rate all of the speakers through your smartphones. So please do try to download this. There is a cocktail reception and a speed dating event again this year. This will be this evening. I will probably give a couple of announcements on this just prior to the Grandmasters session. Please don't forget the gala dinner. So this promises to be an outstanding occasion. We have a mixture of sort of Asian, Malaysian food. We have our own band, the Spinal Chords. I've personally selected their playlist. It'll be an opportunity for us to also network, to catch up with friends, and there's going to be a spectacular fireworks display to close off the evening. So please do try and get your tickets. On the Friday morning, there is a compulsory fire alarm, so that goes off at between 7:45 and 8:30 a.m. This will go off twice for a few seconds. So if you are in the building at that time, please do watch out for that. There will of course be prizes for the best paper, special poster and poster. These are going to be presented at 12:45 on Friday. And this is going to be followed by the afternoon workshops. Now, I don't know if you guys have had a chance to look at the program for the workshops, but it's truly phenomenal. It's a really good program. Please do try and attend. The events are free. Finally, I think it was Benjamin Franklin who said, "Tell me and I forget, teach me and I may remember, and involve me and I will learn." And it is our hope from this Britspine event that it's going to be an opportunity for all of us to learn from each other, to share knowledge, thoughts, and inspire us to improve the standards of care and the quality of life for our patients. I think this is now an opportune time for me to open Britspine 2016. I wish you all 3 fruitful days here, a very pleasant stay in Nottingham. Please enjoy it, have fun, and thank you for being part of this.
Good morning. Could I ask the first speaker to make their way to the podium? I'd like to thank Naz and the organising committee for arranging this excellent programme. And it's an absolute pleasure for BAS to be opening this session. Can I remind the speakers that we are on a timeline, so you have 6 minutes for the presentation. We will take questions at the end of each talk and try not to run over. So the first paper is from Stoke Mandeville.
Yes. Hello everyone, I'm Dr. Piera Santullo, Registrar in Spinal Cord Injury Medicine at Stoke Mandeville. Thank you, the committee and the organization, for inviting us to speak today. And I'm going to present a study that we have done in our center on the use of antibiotics and the incidence of antibiotic-associated diarrhea in patients with spinal cord injuries. And this is our experience. So from literature, it is well known the association between antibiotics and diarrhea, but not a lot is known about the association between this phenomenon in spinal cord injury patients. So the aim of this study was to record the use of antibiotics in our population, to see the incidence of diarrhea associated to antibiotics, with antibiotics, and to assess if there's any seasonal variation on the use of antibiotics and the occurrence of diarrhea. This was a retrospective descriptive study done in our center, the National Spinal Cord Injury Center at Stoke Mandeville Spinal Unit, done between October 2014 and June 2015. It was a cross-sectional study, so analyzing data collected in a particular period of time, which was 4 days, 1 day for each season, where we collected data coming from the patient notes using a standardized questionnaire. We define diarrhea as 2 or more watery stools over 24 hours. Watery stools meaning using the Bristol stool scale, type 5, 6, or 7 in this scale. And for statistical analysis, we use Minitab 14. We reviewed 319 patients. The majority of them were male, with a mean age of 55 years old. The most commonly they were tetraplegic with an incomplete spinal cord injury, lesion or injury. So on the top graph on the left, you can see that out of 319 patients, 76 were on antibiotics, and the top 5 most common causes were urinary tract infection, most common present in autumn, followed by pressure ulcers and wound infection, skin infection, spinal metalwork infection, and osteomyelitis. There was no statistical significant difference across the seasons, but we can say that the most commonly the infection were decreased or were in winter. Going to compare patients on the graph on the left, the bottom on the left. going to compare patient on antibiotics with patient not on antibiotics, we saw that being on antibiotics was associated with the occurrence of diarrhea. In fact, out of 76 patients, 17 developed diarrhea, so the 23% of our patients. Another factor associated significantly with the occurrence of diarrhea was the number of drugs. In fact, greater was the number of drugs used by these patients. Most commonly, they were more prone to develop diarrhea. There was no association between the diarrhea and the between diarrhea and the use of proton pump inhibitor or H2 blocker. And going to compare patients on antibiotics that developed diarrhea with patients on antibiotics that did not develop diarrhea, we saw that older were the patients, more prone they were to develop diarrhea. And another risk factor was the level of albumin. In fact, lower it was, less than 30 grams per liter, it was associated with the occurrence of diarrhea. So mainly our study demonstrated that in our population, in spinal cord injury patients, there's this association between antibiotics and the occurrence of diarrhea. As you can see, the most common cause of infection is urinary tract infection, and as you can imagine, our patients usually manage their bladder with catheters or a self-intermittent catheterization, putting them at risk to develop this infection. And the two risk factors that we identified were the age and the malnourishment. So this study is part of a bigger study. There is a multicentric study involving many spinal cord injury centers in UK and across the Europe. And the main outcome that we want to establish is the causes of infection that we see in our patients, and if possibly to identify if there's any seasonal variation in this infection, and of course in the occurrence of diarrhea. As you can imagine, diarrhea can increase the the length of stay of our patients, so it will increase the cost of hospitalization, and it will be a poorer outcome for rehabilitation. A special thanks to the staff at Stock Mandeville that helped us to collect our data, and thank you very much.
Thank you for keeping to time. The paper is now open to questions. There are some microphones around. Can I ask, do you have any data on the colonization of these patients? Because they've often come from HDU, ITU centres across the country.
Not on colonization, because we just saw patients on antibiotics, and we reviewed the data on these kind of patients. So because of, we usually don't treat with antibiotics colonization. We don't.
And you followed your trust guidelines in terms of prescribing the antibiotics, and the decision to prescribe antibiotics was at a senior level.
It's in collaboration, this study is in collaboration with our microbiologists as well, so yeah.
It is well known that antibiotic use is associated with diarrhea. Do your figures suggest that that effect is greater in the spinal cord injury population, or is it just the effect that we would see in any hospitalized patient?
It's just an effect, yeah, it's just an effect. We haven't compared with the literature on normal patients, so we just saw this effect.
Sorry, was there any specific class of antibiotics causing these complications, and what was the usual indication in these patients, why were they given the antibiotics in the first place?
Urinary tract infection, it was the most common cause. And about the antibiotics, yes, there are classes most prone to cause diarrhea. It will be in the full paper. I don't have this data here, but yes, there are. And usually is ceftriaxone is one of them, and I don't remember all the class, but it will be on the full paper.
Why do you think there's a seasonal variation?
We were expecting to see more urinary tract infection in summer, in the hot seasons because of dehydration, and we were expecting to see more chest infection in winter, of course, as you can see. But on the preliminary data, we just saw that it was most common in autumn, a urinary tract infection. Of course, collecting more data from more centers will help us to see if there's a seasonal variation on
Any others? Thank you.
Thank you.
Hi, good morning. This is a presentation on the management of deep spinal infections in a tertiary centre. It's not working. God. No, it's not working. Okay. Deep spinal infections are rare, but there is a potential for serious consequences if not identified and treated properly and appropriately. The poor outcome has a resultant cost to the NHS. Recent figures from NHS LA show that there is a substantial payout rate where spinal infections have been delayed. And targeted antibiotic therapy is ideal, but can be difficult if broad-spectrum antibiotics have been started early. The Commissioning Spinal Services report has many recommendations, but of particular relevance to our study is that management should have early MDT involvement involving spinal input. There should be a clear pathway to follow, and antibiotics should only be commenced after thorough investigation unless the patient is septic. Given that those recommendations, we're interested to know what practice is like at our unit. We found that currently there are no guidelines for the management of spinal infections, and so we performed a literature review and we found a paper by Vicara et al. This approaches the management in a logical stepwise fashion. Ultimately, the management is divided between operative and non-operative management. As we mentioned before, spinal infections are relatively rare, but there seems to be two groups of effects, the younger children and older adults. It's slightly more common in males, has a 2 to 4% mortality, and the lumbar spine is the commonest area to be affected. Just a quick summary of the pathogenesis. Adults have avascular discs, and they have end arteries and the vertebral end plates. Septic emboli can lead to large infarcts with a subsequent spread to disc and paraspinal spaces. This spread of infected material can potentially cause neurocompression and lead to neurological deficits. From our literature review, in around half of cases we can find a distant focus of infection, and Staph aureus is identified in up to half of infections. So we set up our study to review the management of spinal infections with the ultimate aim of producing an algorithm for our hospital and the hospitals around the region. This is a retrospective study of all the patients with the diagnosis of deep spinal infection that was registered on the electronic database on our hospital over a 1-year period. We also collected data from other electronic patient records. We had a total of 83 patients. Even though we recommend CT-guided biopsy, the yield was actually quite low, but overall, more than 70% of patients appear to have had a good outcome. So as you can see, patients were referred from all across the West Midlands, but only 35 were managed directly within the tertiary spinal unit. The commonest age to be affected was 70 to 79. There's about a 3 to 2 male to female ratio, and the lumbosacral and thoracolumbar were the commonest areas to be involved. Where we could isolate an organism, Staph aureus was the commonest to be isolated. Chest x-rays and blood cultures were the commonest investigations to be completed, and pain was the commonest symptom reported. So this bar chart just illustrates that there was a range of organisms identified and a range of antibiotics used. This variation is probably likely because patients were transferred to our unit and may have been started on different antibiotics. And most patients were on about 2 antibiotics, and most patients were about 2 to 3 month duration of antibiotics. In patients managed surgically, lumbosacral was the commonest area to be affected, followed by thoracic. Just over 50% had a simple decompression, and weakness was slightly more common in these patients. Post-operatively, most patients improved, and no one appeared to have gotten worse. And again, it was mostly negative for growth, for identifying an organism. Patients not managed at our hospital, lumbar discitis was the commonest diagnosis. These hospitals were advised on how to manage the patient and also when to refer, but we don't have the full data for these patients, so we can only assume that they were managed according to the local microbiological guidelines. So, in summary, the majority of cases do not require initial management at a tertiary centre, nor do they require operative management. Antibiotics should only be commenced after thorough investigation where this is feasible, and surgery should be indicated for patients with neurological deficits and spinal instability as the main indications. And so this is our proposed management algorithm. Again, this is just a stepwise approach where you identify the spinal infection, you refer to the unit, and then based on whether they've got indications for surgery or an indication for for surgery, then you would obviously transfer them to the tertiary centre, or if they can be managed locally, then that should be where they should stay. So, thank you very much.